Hi, this is Jeff Klein, editor of RadioGraphics, and today I'm pleased to have here with us Dr. Katabathina from the Department of Radiology at University of Texas Health in San Antonio, Texas, who is the first author of one of our featured papers in the current October 2020 monograph issue of Radiographics. The article is entitled Decoding Genes, Current Update on Radiogenomics of Select Abdominal Malignancies. Dr. Katabathina, welcome to our October 2020 podcast.
Thank you so much, Jeff, for the opportunity. I'm glad to be part of this program. And before I start anything, I would like to thank my co-authors for their timely help and great images and great support.
Thank you very much. This is obviously an emerging topic for radiologists that interpret abdominal imaging studies in the era of personalized medicine. Can you provide our audience with a brief description of what is meant by radiogenomics and how it impacts our work as radiologists?
Yeah, definitely, Jeff. Rapid advances in the field of tumor genomics have caused significant paradigm shift in our understanding how tumors develop, how they grow, and how they spread. And genetic changes determine tumor pathways, how the tumor looks on microscope, and how a tumor behaves. So better understanding of genetic abnormalities and underlying tumor pathways have really changed the way we classify our tumors, how we treat our patients, and how we prognosticate. So just to give an example, detailed studies of rare cancer syndromes such as von Hippel-Lindau disease has allowed us to better understand tumor biology of sporadic tumors such as clear cell renal cell carcinoma, which is the most common and most lethal cancer. So bottom line, the genetics have changed significant way we practice the medicine. So once this is changing, as a radiologist, the question is, can we predict the genes based on the imaging findings? So we look at image daily. So can we predict the genetic abnormality based on the imaging findings? Then here comes the radiogenomics. So radiogenomics refers to a field that links or bridges imaging features to tumor genomics. So radiogenomics aims to correlate imaging features with gene mutations and gene expression patterns. And it may range simple RadPath studies to texture analysis to models driven by artificial intelligence. There are different types of radiogenomics. And so bottom line, as a radiologist, we are trying to see genes in the images. That's the radiogenomics. And the second question is how radiogenomics impact our work as a radiologist. So understanding radiogenomics definitely will add a layer of complexity what we have been doing as a radiologist. And in future, we need to invest more time in educating ourselves about the sophisticated world of tumor genomics and spend more time in qualitative and quantitative analysis of tumor features that we can glean from imaging studies. And all these extra efforts are worthwhile and gratifying as they will ultimately benefit our patients and their families. Because if you identify a gene in one person, then entire family we can help. We can help with that genes. And right now, we may be the first physicians to suggest a possible cancer syndrome or any other syndrome in a patient with specific imaging findings. But in future, we may play a bigger role in the diagnosis and management of these patients with a wide spectrum of sporadic tumors based on all this genetic knowledge.
Terrific, thank you. Now, the first part of your article addresses hepatobiliary neoplasms, beginning with hepatocellular adenomas or HCAs. You describe 4 molecular subtypes, the first one being inflammatory HCAs, which have specific associated mutations. You detail the MR characteristics of inflammatory HCAs in Figure 1. Can you describe the imaging features as we review this figure?
Yeah, Figure 1 has 5 parts, 5 images in Figure 1. 4 are MR images and 1 is a path image. And this figure belongs to a 35-year-old woman with inflammatory hepatocellular adenoma. And there are axial T2 weighted image, GADAC state enhanced MR images during the arterial phase, portovenous phase, and hepatobiliary phases that demonstrate a well circumscribed, diffusely T2 hyperintense lesion in the right lobe of the liver that shows intense enhancement during the arterial phase with mild persistent enhancement during the portovenous phase. And the lesion is diffusely hypointense during the hepatobiliary phase, suggestive of inflammatory hepatocellular adenoma. And the path picture shows multiple dilated sinusoidal spaces and unpaved arteries. The pathology behind this inflammatory adenomas is sinusoidal dilatation. So sinusoidal dilatation is the typical feature of inflammatory adenomas. And as a radiologist, we will try to identify that part on MR imaging that appears as T2 hyperintensity with intense enhancement and progressive, preserved enhancement in the portovenous and delayed phase that shows figure 1.
Terrific, thank you. Now, you described the importance of gadacetic acid enhanced MRI in the hepatobiliary phase to characterize HCAs and distinguish these from focal nodular hyperplasia. Let's look at figure 4 and review the findings here in gadacetic acid positive HCAs in 2 different patients.
Traditionally, regarding hepatic adenomas and FNH, we have been using gadacetic acid enhanced MRI to differentiate between adenomas and focal nodular hyperplasias. And in this process, hepatic adenomas are typically hypointense on the hepatobiliary phase, whereas FNH are hyperintense. As we are getting new information on molecular features of these hepatic adenomas, we are seeing some hepatic adenomas that are hyperintense on delayed phase or hepatobiliary phase imaging. So now it is getting really difficult to differentiate between FNH and hepatic adenomas based on just delayed phase or hepatobiliary phase imaging. And figure 4 shows 2 different patients with proven hepatic adenomas that mimic FNH on the imaging. So patient 1, that is figure A and B, shows inflammatory hepatocellular adenoma in a 34-year-old woman, axial T1 weighted image and coronal T1 weighted post-contrast image in the hepatobiliary phase shows an arterially enhancing focal mass that in the caudate lobe, which is mildly hyperintense on hepatobiliary phase. Based on these imaging findings, this can be hepatic adenoma or FNH, but this was proven to be hepatic adenoma, inflammatory type of hepatic adenoma on pathology. And the second one is unclassified hepatocellular adenoma in a 25-year-old woman. Again, axial T1 weighted MR, coronal T1 weighted post-contrast hepatobiliary phase MR shows again an intensely enhancing lesion that is hyperintense on the delayed phase imaging. Again, this lesion mimics FNH, but turned out to be unclassified hepatocellular adenoma. The teaching point from these 2 patients are some hepatocellular adenomas mimic FNH on imaging, and we must consider the non-contrast features such as T2 hyperintensity and other features before making a confident FNH diagnosis. Because if once as a radiologist we call it as FNH, they don't do anything, and that really affects the patient.
Great, thank you. Now, moving on to hepatocellular carcinoma, you described 2 different phenotypes of non-proliferative and proliferative HCC, which correspond to well-differentiated and poorly differentiated histiotypes, respectively. And you summarize these in Table 2 in your paper. You describe the imaging features of aggressive tumors, such as macrotubercular massive or MTM type HCC. Can we review Figure 6 in the article, which illustrates some of the features of this lesion?
Figure 6 belongs to a 58-year-old man with pathologically proven macrotrabecular massive type HCC. This figure includes axial diffusion weighted contrast enhanced MR images during the arterial phase and portovenous phase, demonstrates a heterogeneously enhancing mass in the liver, which became isointense to the adjacent liver parenchyma on the portovenous phase. And this lesion has central necrosis, and this was proven to be macrotrabecular massive type HCC on pathology. And the importance of characterizing this is some HCCs behave really good and some hepatocellular carcinomas behave really bad. And this is the first time I think in radiographics literature where we are doing this classification, HCC classification, and the bad types of HCC, they typically are larger in size, they are multifocal, and we can see multiple satellite nodules and tumor involvement of the vein, adjacent portal vein, and other findings such as increased FDG uptake. So as a radiologist, we are trying to figure it out which cancers behave well and which cancers don't behave well. So here comes this, features. And for example, these patients can get, like, in the future, what I predict is these patients can get extra points in the transplant list so that they can be transplanted before when compared to the non-aggressive hepatocellular carcinoma patients. And the treatment also, if it is really bad type of cancer, then the treatment should be aggressive when compared to the mild type of hepatocellular carcinomas.
Great, thank you. Now, after discussing cholangiocarcinoma, the article discusses gastrointestinal malignancies, including GISTs, gastric carcinoma, and colorectal carcinoma. Table 3 in the paper summarizes the mutations that are involved in the imaging features and clinical characteristics and the implications for each of these 3 GI malignancies. Now, focusing on colorectal carcinoma, let's review figure 14, which shows an example of microsatellite instability colorectal carcinoma, and have you describe the genetics and imaging behind this, particularly the association with Lynch syndrome.
Yeah, this figure belongs to a 35-year-old woman with Lynch syndrome. In this, the coronal contrast-enhanced CT image demonstrates a large mass in the ascending colon and cecum. And the second part of the figure is a pathologic image. This was proven to be microsatellite insufficient tumor based on the loss of nuclear staining of the tumor cells for MSH2 stain, which is one of the typical stain used for Lynch syndrome. So the reason behind this cancer is the teaching point from this cancer is tumors, colonic tumors, which are MSI positive, that is microsatellite unstable tumors, typically develop in the right colon, and about 70% of the tumors are proximal to the splenic flexure. So as a radiologist, whenever we see ascending colon or transverse colon cancer, we should alert the pathologist. This could be secondary to microsatellite unstable tumor and Lynch syndrome. I just want to give you an example which I encountered in a tumor board 3 months ago here at UT. So this patient is a 83-year-old lady, and she had pancreatic cancer. And we were discussing pancreatic cancer in the pancreatic tumor board. And I noticed her right colon is absent. So she had right hemicolectomy 25 years ago. And I noticed that, and there is a pancreatic mass. And I think I was writing this paper, and I was reading so much about that. And I said, oh, wait a minute. This looks like a Lynch syndrome, because Lynch patients can develop pancreatic cancers, and they are right-sided colon cancer. So in the tumor board, I suggested, and everyone was looking at me, hey, what are you talking? Because they never thought of, like, going in that direction. And I said, hey, this could be Lynch syndrome because of these 2 findings together, and please do like stains accordingly. And pathologists agreed with that thing. And that patient turned out to be a Lynch syndrome associated pancreatic cancer. And so after that, they did familial testing and all those things. And a couple of other family members turned out to be Lynch positive. So I felt really happy based on that case, that my knowledge, whatever I'm working on this paper and reading this, really helped to save one family there with the Lynch syndrome. So bottom line teaching point is, whenever as a radiologist, if you see right-sided colon cancer, always think about Lynch syndrome.
That's a really good example of how you can really contribute to the care of a patient by making these observations as a radiologist. So thank you for that.
Yes.
Now, for the molecular subtypes of pancreatic malignancies, you discuss obviously adenocarcinoma and neuroendocrine tumors, which I'll mention to our audience is the subject of another Radiographics article by Lokesh and colleagues in the current September-October 2020 edition of the journal. And then you discuss renal cell carcinoma and pheochromocytomas and paragangliomas. Regarding clear cell renal cell carcinomas, you note that 90% of these tumors are related to mutations in the short arm of chromosomes 3p or X that contain, among other genes, the von Hippel-Lindau gene. Figure 19 shows a clear cell carcinoma associated with BAP1 mutations. Can we review this case?
Yeah, absolutely. So figure 9 belongs to a patient, 80-year-old man with clear cell renal cell carcinoma. And here we have two images. One is axial unenhanced and other one is coronal contrast enhanced CT image that shows a left renal mass with scattered calcifications and ill-defined margins with peripheral enhancement and central necrosis. And based on the imaging findings, definitely this mass is a clear cell renal cell carcinoma. But the other additional findings in this patient is irregular renal margins and calcifications. Calcifications are as such not common in renal cell cancers, and BAP1 mutation is one of the association with calcifications and irregular margins in clear cell carcinoma. So this tumor was proven to be clear cell RCC with BAP1 mutations on pathology. And the teaching point is tumors with the BAP1 mutations demonstrate ill-defined margins and calcifications and commonly are high grade on pathology.
Great. Thank you, Venkat.
Yes.
So any closing comments regarding the future of radiogenomics, particularly in the assessment of the temporal evolution of imaging findings as they relate to patient prognosis and management for some of these tumors?
Yeah, definitely. Radiogenomics has a greater role to play in the future of oncology. Personally, I think as a radiologist in next 10 years, in addition to what we do, like our impression always has to include something like regarding genetics. So colon cancer, probably Lynch syndrome, renal cell cancer, probably BAP1 mutation. So I predict that because with this personalized medicine, the things are changing so rapidly in the field of genetics. And I have seen many radiologists are not really interested in this field of genetics. Like, oh, how can we say that? But lately, that interest has been changing. That thing has been changing, and many of the radiologists are now talking about genes. Because once we go to the tumor board meetings, our colleagues would always talk about some genetics. Say, is it exon positive? Is it exon negative? And unless as a radiologist we know about them, we are not going to contribute to the patient's care. So bottom line, we should be learning all these things, although little bit difficult for a radiologist because we always look at the images and talk about the images, but we need to learn about that. And second thing is the qualitative and quantitative tumor features that we obtain from imaging studies may not only help in the diagnosis, but also we can stratify the patients from responders to non-responders, and we can predict the earlier signs of drug resistance so that we can prognosticate which subtypes of tumors can respond to that particular drug or which may not respond to the drug. And other thing, once we understand the molecular level events that happens in the tumor, it's always, we can give same thing with the reproducible imaging techniques. Once we know this molecule can present like this, so on imaging, we can search for those findings and we can tell the clinicians, oh, this could be that molecule and we can try this drug. And other thing regarding temporal evolution, currently biopsy is the only option we have to see that, how the tumor is behaving over the time. But unfortunately, biopsy is an invasive procedure and we have to do it at multiple times, which is not practical. And given the tumor heterogeneity, even if you biopsy one area, the other area you may be missing. So to study the tumor completely, the better option is imaging, where we could see tumor in toto rather than just biopsying one area. And hopefully in the future, coming next 5 to 10 years, with advances in the imaging techniques and use of artificial intelligence technologies, we may be able to predict that temporal assessment of tumor dynamics in a non-invasive way, as we do as a radiologist. And advanced information on that may help in better management and prognostication by reliable forecasting of tumor behavior. So this is genetics is going to be future of radiology, and that's what I would like to conclude. And all radiologists should be ready to learn about genes and ready to implement that in their practices.
These are very important points you make. Thank you. So Dr. Katabathina, I want to thank you for taking time today to discuss your paper on Decoding Genes, current update on radiogenomics of select abdominal malignancies, which can be found in the current October 2020 monograph issue of Radiographics. I'd also like to bring to the listeners' attention the commentary by Dr. Antonio Luna of our Radiographics editorial board that accompanies Dr. Katabathina's article in the current issue. Venkat, thank you so much for your time today.
Yeah. You're welcome, Jeff. Thank you so much. And see you soon sometime at RSNA meeting soon.
Same here.
Thank you.
Very much.